Today's conversation is with Dr. Kedar Kulkarni, who's an interventional cardiologist. And given a lot of the conversations that have been happening on the group, I think it's very, very timely. So before we get our conversation started with Kedar, I just want to do our usual set of things. Please stay on mute and type away your questions in the chat window. I'll make sure to get to them at the end. Um, for those who are already not members of the community, it's easy to join. Lots of reasons to join. And if you want to join it, just scan the QR code or use that URL at the bottom to join the community. Um, I've been getting a lot of questions about upcoming talks. So I thought I'll just share with you our calendar for the next 3 months. We've got fascinating speakers starting today with Kedar, but then we have experts from around the world in all the different verticals. So neurology, thyroid, we even have the science of Ayurveda and inflammation. In September, we have a fascinating talk on mental health, how you can prevent it through art, and so on and so forth. So a lot of really, really good experts that will be speaking at our standard Thursday, 9 p.m. India time, 8:30 a.m. Pacific time. Uh, for those who have joined the community more recently, you can get access to all the previous speakers' conversations. I'll make sure to post this on the group with the links so you can click on the link and find the entire talk that was recorded. Okay. I wanted to also announce the latest set of discounts. Last week, we had discounts for the imaging tests, the coronary calcium angio, stress test, and all of that. This week, we have actually taken your feedback. We had done a poll about 10 days back, and we had asked the community members, what is it that you would like to see us go get discounts for you? And the number one request was for blood tests. And so very excited to announce that we have actually gone and done right now India-wide deals. So we don't have a partner in the US as yet, but for India, we've gone and done deals pan-India with Metropolis and Lalpath. We purposely chose these two, like we choose all our partners based on whether we are willing to use it on ourselves and our family members. There are other labs, but I know, and all of our doctors on our call, they send their own samples to these two. And so they're the two we went and got these discounts for. So across all their tests, it doesn't matter whether it's only for heart health or women's health, doesn't matter. They have a huge list, and across the board, there is going to be a 25% discount on whatever Metropolis offers. So if you were to go to Metropolis, whatever rate you see there, you'll get 25% off that if you are a member of the Longevity Lab community. At Lalpath, you see a 20% discount. The other thing that we have done, and I don't know why this thing is showing. Okay. The other thing that we have done is for pap smears and mammograms, couple of them like NM Medical does both. Metropolis does only pap smear. There also we got a different discount, a slightly higher discount than the 25 and 30% or 25 and 20%. But one of the most interesting things we have done is we know what tests we would like for ourselves and our family members to do. And so from Dr. Melinkari and other experts, we put together, and I'm going to show you that on the next slide, a list of parameters that we would recommend get tested in the annual health checkup. And for men below 55, men above 55, women below 55, women above 55, and a standard heart health assessment. It's a very specific focus on heart. We've got the market rates, and that's in that first column with numbers. And then next to it, you see what rates we've been able to negotiate on your behalf with these three different labs. As always, We only recommend things that we are willing to do on ourselves and our family members. If you want to get access to this, you send the preventivehealth.ai account within the community, your name, the product you want to get tested for, and which lab you want to go to, and we'll generate a discount code, send it back to you. After that, the entire transaction is between you and the lab. We do not play any role. We don't take any cuts, any commissions. We're doing this as I've mentioned before, so that you guys benefit. This is not the way we intend to ever make money. So hopefully this is exciting enough for those of you who are planning to do any tests, and not just in the next week. This is for the foreseeable future. And so that's that. Here is the list of tests that are in the comprehensive annual health check panel. The ones in black are for everybody. And wherever there are specific tests for women or men above or below a certain age, those are specified in the orange text. The tests that are bolded, the parameters that are bolded, they are part of our heart health assessment package. And again, we designed this, but we designed this so we could go to these labs, get them to create these panels. But we are not involved in any commercial agreement here. We don't get any cuts from them, you, or anyone else. We've designed it to ensure that it is as comprehensive a panel as it can be, that we would want to do. And the one comment I did want to make, because a lot of the doctors on our community want to ensure that the thing that you've already seen on this on the community is, our goal is to make health not be something that causes you anxiety, but rather it helps build your awareness. And so, because we provided this comprehensive panel doesn't necessarily mean you have to do everything. This is what we recommend generally one should do. But speak to your doctor if they think that it's not, some things don't need to be done or something else needs to be added. You in any case have the option of adding other tests with that discount. So don't let this cause stress or anxiety. Use it, and use the community, and use us as someone who's the trusted confidant in your corner looking out for you. All right. So that's that. Our speaker for next week is Dr. Petrus Vardia. He is with Jaslok, and his expertise is in neurology. And so a fascinating individual that we'll be talking to next week. But moving on to the man of the hour, and it's Dr. Kedar Kulkarni. Kedar is obviously one of the top interventional cardiologists in Pune. But, I had a chance to speak to Kedar before this, and I just find his approach to, how he thinks about things. And Dr. Rashida Melinkari, who is on the call with us, has worked very closely with Kedar, and like Kedar was telling us earlier, sits across him. And she just has the absolute best things to say about Kedar. And I've known Rashida long enough that if she is so full of praise for somebody, then they absolutely deserve it. And so, without further ado, Kedar, welcome to the community.
Well, thank you. Thank you very much for inviting me. So let's get started.
Perfect. And so I'm going to get, let me start presenting. All right. So, Kedar, I know, in the last few weeks, and I would say it's not just the last few weeks, in general, one of the top topics that people in the community have questions about, and I think this is true around the world, is on cardiovascular health, because it is the biggest killer of humankind. I think 40% of all deaths globally are from cardiovascular disease, or from cardiovascular related diseases. And so maybe we can start with something very simple. For the common man, for the people on the community, for us, how would you explain the role of the whole cardiovascular system? Why is it so critical to get right, and why does it, when not managed, kill so many people?
Well, the cardiovascular system is, I think, second most important after the neurological system. It supplies blood, and through the blood, our entire body receives oxygen, nutrients, all the hormones that are secreted, and it supplies them and also collects the waste, that is carbon dioxide from the peripheral tissues. And so, basic cardiovascular system, the pumping of the heart, the conduction of blood through blood vessels to the entire body, is that way second in importance after the neurological system. And so I think the cardiovascular system is its health is most important. And over time, see, initially our level of activity was quite high. That is, people, even children, they used to go out and play, while people today are stuck to their devices, either for entertainment or for job. And nowadays, sitting is has become the new smoking, because work from home, and especially after this COVID thing, it has reduced activity, and because of reduced activity, the heart gets trained in performing its own work better with more activity. So, more the activity, better it is for the heart. That is how it is simply put.
Yeah. Yeah.
And I
Yeah.
would say more activity in the form of aerobic exercise, not weightlifting. I would equally give weightage to both muscle training and as well as cardio.
Yeah. I mean, there are a couple of very important points over there that you made, Kedar. One is uh, both have a role to play, right? Strength training helps with a certain aspect, uh,
Yes,
but and that's why they say muscle mass is one of the key predictors of longevity. But so is VO2 max, and
yes,
that comes from increasing your heart rate significantly a few times in the week at least,
yes.
right?
It,
Yeah, go ahead.
it is 80% of the target heart rate is what is said. Target heart rate is calculated as 220 minus the age of the patient or of the person, and 80% of that. So, say if I'm very bad at mathematics, that's why you see this. But 80% is what you can sit and calculate. And nowadays, heart rate measurement can be done through a smartwatch or through the sensors on the treadmill. And based on that, if you feel palpitations, if you're feeling unduly breathless, then you slow down, come to get some breathing space, and then increase the heart rate again. But a safe limit is 80% of the target heart rate.
Yeah. Yeah. So just to give everybody a sense, I'm because I'm not good at biology. That's why I can do the math part. For let's say a 50-year-old,
Yes,
the 220 minus 50 is 170, and
yes,
50% of 170 is about 140. So
80.
hit 140 beats per minute, or if your wearable shows it, or whatever other form of measurement you have of your heart rate, then you are definitely doing a good job for your heart.
Yes, and you maintain it for as long as you can. If you feel breathless, then you slow down again, and then make it touch that much at the next time. And so do that kind of workout at least for half an hour.
Yeah. And how many times a week would you say, Kedar? Half an hour, 3 times a week, 2 times a week?
Do 5 times a week.
Oh, 5 times a week.
If you say 5 times a week, it will be 4 times. If you say 6 times, it will be 4 times of 5 times. That's how.
Yeah.
Because everybody finds some kind of thing to miss a day.
Yeah.
So you are unwell, you had a call in the morning, you have a meeting. So some reason crops up.
Yeah.
So you set a target which is probably unachievable, and then you could achieve it.
Yeah.
So 5 चाहिए तो 7 दो.
Yeah. In fact, I mean, my personal routine is I make sure I do cardio, as in like, Peloton or some sort of cycling type of thing twice a week. soccer twice a week, so I get my 4 times that way, and then
Yes.
3 times a week is strength training.
Yes, that's right.
Right. Um, so, given that, one of the things that we keep reading about, hearing about, is heart disease seems to strike out of nowhere, right? Unlike some of the other things which are so visible, many people are walking around with heart disease, don't even know about it. I know I talk about it where I was diagnosed 10 years back and I had no clue. And so, given it's so asymptomatic, the way heart disease builds up, um, I know there was this one quote by Dr. Devi Prasad Shetty. He said, Indians should assume that they have heart disease unless proven otherwise, rather than the default being the what we usually are. So, what's your take on it? Is that the right way to think about it?
Actually, Dr. Devi Prasad Shetty's approach in a way is correct because Indian subpopulation is at increased risk of heart disease, coronary artery disease. Because when I say coronary artery disease, it means the blood supply of the heart, that blood supply accumulates cholesterol within its wall. And that cholesterol is, if it is not blocking the blood supply, then it won't give any symptoms. And one not so fine morning, if the covering over the cholesterol pool, it breaks, then blood comes in contact with the cholesterol pool, and it sets off a reaction where, see, when you get a cut, you get a blood clot in on your skin. So the same process of clotting starts in the heart, the blood supply of the heart. So blood thinks that it is exposed to air, and so it starts clotting. And because it is a very quick process, it completely occludes within a few minutes. And so because it occludes, then it gives symptoms. And it is such a vital organ, and the that it could have a mechanical complication, that is pumping failure, so drop in blood pressure, or electrical short circuit. That also would cause a drop in blood pressure, and that's why it causes the death of the patient. So, in a way, saying that every person beyond 40 should undergo a CT coronary angiogram, he is not entirely wrong, although he had faced flack for saying such a thing. My thing is, at least do a stress test, 2D echo, and the lab parameters, which you have already discussed. And if those show some abnormality, and if the person's overall clinical profile, that is, he's smoking, he's obese, his job is involves him to sit at a place for more than 8 hours or so, and on that you can take a call whether he has to do an additional CT coronary angiography, or only these tests are enough. So I won't exactly rule out Dr. Devi Shetty's statement, but he is correct in a sense.
No, but I think what you said is actually pretty fascinating, because if you can do a coronary angio, do it, but you don't have to go all the way. But do something, and that something is the list of things you said, right? Test.
Yeah.
Test is much easier to do, and
Yes.
and if it's showing even some signs, absolutely do the CT angio, right?
Yes. If the person is getting tired at a very early stage, the person is obese, the person has got pre-diabetes, abnormal lipids, and he smokes, then it is worthwhile doing a CT angiography.
Yeah, and the other factor that I imagine is also included is if there's any family history, right?
Yes.
Then definitely
Yes.
do it.
Yes.
Right. Yeah, got it. Also, just for people on the community, last week, some of the tests that Kedar just spoke about, the stress test, the tooth
2D echo,
code, maybe even the Doppler, those are all,
carotid Doppler.
yeah, carotid Doppler, they're all included in our list of tests that we've been able to get very meaningful discounts from the imaging labs. So you have access to all of these. If and when you decide to do it, you know where to go to. But I think the important point here is, do not wait for symptoms, especially
Yes.
after 40, to think about doing any of these things. Do them proactively. I know I'm very glad I did it because had I not done it, I would have become a statistic by now. So, Kedar, at the age of 43, okay,
Hmm.
my calcium score was 266, but there were no symptoms. I was
Yeah.
playing soccer and I did not feel breathless, right? So I got lucky because my wife intervened. She was my interventional cardiologist for that day. Uh,
That's
but
usually wives are.
sorry, good.
Then I said usually wives are.
Yeah. So if you are not convinced, guys, please talk to your wives. And if the wives are on the call, please push your husbands, because I can't stress enough the need to not wait to see symptoms to do some of these tests. Okay. Um, one of the other things you were mentioning, and I thought might be a good idea to talk further about this is, Kedar, there are, people say, oh, he got a heart attack, he got a stroke, she got this. What are the differences in these two or three major issues with respect to the heart?
Uh, Stroke is a neurological event. That is, he has the blood supply to the brain gets occluded. The same process which I talked about, that the blood comes in contact with the cholesterol pool and it forms a clot. So what if the thing happens in the heart? It gives a heart attack or a relative of it. That is, it's a spectrum, non-ST elevation MI to ST elevation MI and all that. But ultimately, it all involves coronary work, that angiography and angioplasty. And if the same process, pathology, happens to the blood supply of the brain, then it gives rise to a stroke, that is a paralysis. Uh, uh, well, I would like to ask you a question again. Could you help me with the question?
Yeah, no. So I think you've answered it. There are two major things, right? Strokes and heart attacks.
Yes.
Heart
So
attacks, yeah.
stroke is due to either a blood vessel getting blocked, occluded, or a blood vessel rupturing. If the vessel ruptures, it is diametrically opposite of the treatment is diametrically opposite. It involves the control of blood pressure and all that. It does not involve the blood thinners that we usually give. And if it is due to blood vessel getting occluded, then it involves blood thinners and cholesterol lowering drugs. And as for the heart, we don't see a ruptured blood vessel, but we see an occluded blood vessel, and which is the cause for either an unstable angina or a non-ST elevation MI or a ST elevation MI. That classification is for us.
Right.
You need not delve into it. In all this, you will have chest discomfort, heaviness in the chest, sweating, and nausea, vomiting, and which increases on walking.
So, and it's interesting you mentioned that. I know one of the things I've heard from a couple of people who had a heart attack uh, was, in addition to the things you described as early warnings, right? Like, oh, I'm beginning to feel this heaviness or shortness of breath, or is pain in the arm, left arm. Is that a common thing that can happen?
Yes, especially if it increases on walking or doing any kind of physical activity, then it is strongly suggestive of heart disease.
Got it. Yeah, and at the same time, two or three people that I know, they felt really uncomfortable. They didn't want to take a chance. They went to ER, and then they found out that it was a digestive, acidity
Yes.
issue. And so, some people, if it's better to err on the side of caution. If you
Yes.
feel anything, just go. Don't
Yes.
wait. And I want to share one interesting story. So I have these two friends. One is an engineer, one is a doctor. They're in India, they're in Pune. Whenever I go back, I play football with both of them as part of a group. One time, we were in the middle of the game. I was not there that specific day, but they were playing. And the doctor, he's a really good football player. And he complained about some chest pain, and the engineer told him, "Oh, we better not take a chance. Let's go to the hospital." And the doctor told him, "No, no, no, don't overreact. It's just a digestive issue." Okay.
Mm.
The engineer said, "I don't care. Uh, I've heard too many stories. I'm going to take you. Worst case, there's nothing." So he forced him. They went to the hospital. This guy's wife happened to be working at the hospital, so she already got the stretcher out. They took him in, and he was in the middle of having a heart attack. And to me, the moral of the story was, don't trust your instinct. Doesn't matter your expertise, because this
Yes,
shows up in very weird ways.
yes. And actually, cardiovascular system, talking about the blood supply is one thing, but having unexpected results. You have heard of film actors walking on the treadmill and then dropping down dead and all that. There are other conditions also of the heart called as hypertrophic cardiomyopathy, in which there is a genetic predisposition in which the person's heart has asymmetric thickening. So the heart, so that is picked up on an echocardiogram, and that is he is born with it. He is destined to manifest it sometimes in his life. It can be at 6 to 8 years, or it could be at 20 to 40 years, or even late. But if the person has this and it is undetected, and he has some physical activity which he is not used to, that is बहुत दिनों के बाद 25वां 25th get together हो गया, people met in Goa, and then everybody met the doctor, and everybody said, "अरे कितना मोटा हो गया, अरे कितना गंजा हो गया." So then that mota ho gaya, he feels hurt, his ego is hurt. So the next day he wants to get rid of the entire fat in one day. So he starts using the treadmill. And that's when the hypertrophic cardiomyopathy starts acting up, and because it is unaccustomed exercise, he drops dead.
Yeah.
So that is one hypertrophic cardiomyopathy, and rare conditions like long QT syndrome and all that, which are not in any way related to the blood supply, but those are also an important things which you have to consider in a person's overall health.
Yeah, and that's why what you said earlier is very critical. Is if you suddenly decide you want to exercise, if you feel it's pushing it, stop. Let
Yes.
it recover, then go back again. Don't push it, because you know what? If I push it more, I'll lose weight faster. It might have
Yes.
negative effects rather than positive.
Yes.
Right?
That's hitting it on the head.
Yeah, yeah. Though, beyond the traditional cholesterol panel, right? People have just historically always said, "Oh, my total cholesterol is less than 200 I'm okay." Now, I think people are becoming more cognizant of the fact that that's not a good enough number. Because you're adding supposedly one good thing and one supposedly bad thing, and taking the sum doesn't provide much
Yes.
value. What do you look at, Kedar, when you look at somebody's test results? Where do your eyes first go? What parameters matter the most to you?
Actually, it's first the LDL cholesterol, but nowadays even apolipoprotein B, that is a molecule which is a protein molecule associated with many atherogenic lipids. So it could be LDL, IDL, intermediate density lipoprotein, low density lipoprotein, very low density lipoprotein. So all these contribute to atherosclerosis, that is the cholesterol deposit which I was talking about. So apolipoprotein B, ApoB levels are also measured, and getting them low by use of statins is helpful. HSCRP, lipoprotein little a, that is, there is a drug in the trials which is still not out, but probably it is in the pipeline, which could be out in a couple of years or maybe 5 years or so. But a drug which is specifically lowering lipoprotein little a. Because initially I used to think that what is the use of measuring lipoprotein little a if by that lipoprotein little a elevation is bad for you. But there's nothing that will lower it. So apart from giving statins, regular exercise, there is little one could do. But now a drug is going to come which is going to lower that lipoprotein little a. So I think more and more people will get that lipoprotein little a measured, because if it is found high, then the drug, there will be a drug which will lower it. Then HSCRP to look for inflammation in the blood vessels. Mm,
Homocysteine.
yes, homocysteine also.
Yeah, yeah. So I just want to quickly provide everybody on the call, because there are some very, very important points made by Kedar here, and I want to translate into very simple, like a cartoon view of what all these mean, right? All these versions of LDL, so the LDL, VLDL, IDL, they're all various stages of the bad cholesterol, and they all carry this marker called the ApoB protein. Okay? And so now LDL cholesterol is most of the total bad cholesterol. But if you really want an even better marker, then use ApoB. And ApoB is unlike the LDL level, which is the cholesterol volume. ApoB is more the cholesterol, the bad cholesterol particles. It's almost like if there are more cars on the road, doesn't matter how many passengers are in the car. If there are more cars on the road, there's a higher chance of an accident, right? And that's what ApoB measures, and this is a very critical thing are made. CRP, like you said, is the inflammation. Inflammation in general is a bad thing. We don't want too much inflammation. And so now it's not a great marker, because you can, if you catch a cold, also your HSCRP will go up. But in general, over time, you should see that relatively low. Homocysteine is another such marker. Fasting insulin, I think, Kedar, is also a good marker. But
Yes.
the important point that Kedar made is about LP little a, lipoprotein A. This is a genetic marker. And the point that Kedar was making is all the other parameters we spoke about are modifiable through lifestyle and medicine. Lipoprotein A is a genetic marker which historically has not been addressed through any medication or lifestyle. You could just not move it. Doesn't matter what you did. Now there is a thing under FDA approval process. In fact, some of our members have been on that trial. They don't know whether they got whether they were in the control group or the actual group, but when that comes out, that's a new tool in the toolbox to help lower the risk. The one advantage I see of knowing your LP little a is, if your LP little a is high, you know that relative to somebody else who lives the exact same lifestyle as you, eats all the exact same things as you, but if their LP little a is much lower, your risk is higher. You can't just say, hey, I ate the same as that guy. How come I'm in more trouble? Well, if your LP little a is high, you should be aware, so that you'll go do your checkups, and you're testing more regularly. Kedar, would you say that's a fair statement?
Yes, that's right. You would do that, but then the fact that as a human being, I'm responding that if you can't do anything about it, then why measure it? Was my first take as a person, when I went through this lipoprotein little a. But now it is going to be lowered, so now we can do definitely. I mean, okay, I'm living doing workouts 5 days a week. I'm eating the healthiest of food and everything, but still my lipoprotein A is elevated. I mean, that is like you are being written off, no? That you are going to suffer. So that was distressing. And now this development of a drug has actually raised the hopes.
Got it. Yeah, agreed. One of the other numbers we keep hearing either is, oh, I got my calcium score. I shared my number earlier. And a lot of questions on the community are around, hey, my calcium score is only 2 or 0. What does that mean? Versus my calcium score is 40, 50. And I understand it's a function of age, right? Of course, as you get older, it will go up. But the longer it stays at 0, the better. But at the same time, just because it's 0 doesn't mean that it has caught all the soft plaque. Can you just provide some sort of education of how for us, for the common person, how should we think about this calcium score?
There is a cutoff limit for this. Actually, calcium score means calcium is deposited in any tissue which is unhealthy. So, be it a scar on the skin, be it so similarly, it's on the in the blood vessel, cholesterol is deposited. It is deposited within macrophages. That is the blood vessels, the inflammatory cells of our body. It is deposited within those cells, and those cells go in the endothelium, and then they die, and then they release the cholesterol. So cholesterol becomes unhealthy, and all unhealthy things have dystrophic calcification, that is that abnormal calcium. And so calcium has a property of not of being radio opaque, and so a CT coronary angiography for calcium score was devised. So calcium is there means it is inferring that there is cholesterol, and so cholesterol is present above a certain limit. So calcium also is present above certain limit. So if the calcium score comes above a certain limit, then you either subject him to a stress thallium, that is an advancement over the regular stress test, or do a conventional coronary angiogram. That is, inject a contrast medium and see if there is a narrowing of the lumen.
Yeah.
So a cutoff limit is present for this calcium. If it is high, then you and you're asymptomatic, then you follow things like statins and all that. If it is high and you are having symptoms, then you should do a coronary angiogram. There are no two ways about it.
Yeah, understood. The one question that comes up is, and I think you referred to it, and we spoke about LP little a and a couple of other things. But if there are two people who live the same lifestyle, but because of genetics, they can have very different outcomes, right? So, on one hand, heart disease and these things are called lifestyle diseases because lifestyle plays a very important role, right? And that should never be forgotten because you can always just blame it on our genes. We can't just blame it on our genes. But at the same time, genes do play a role. So, let's talk a little bit about that, Kedar.
If you have a strong family history in the sense of your own parents suffered from a heart disease at an early age, say father at less than 40 and the mother less than 50, then it becomes a significant family history. Or if the maternal side, her brothers, that is apne mama or our kaka, if any of those have had symptoms, then it is likely that you could have inherited that thing from your relatives. If it is a strong family history, then at least do a stress test at an early age. Nowadays, I'm seeing patients of 35 years of age. So nowadays, I'm doing stress tests for even 30-year-olds who say that they have chest pain. But here, I wouldn't wait for chest pain. I would like to do a stress test and look at the patients at least if the stress test is not showing anything abnormal and his cholesterol, lipoprotein little a's, homocysteines, all that is normal, then at least you can wait for a few years. If he's a young person, 20 years or 25 years, maybe wait for 3 years and then repeat the test.
Got it. So, and how often should a stress test be done?
If it is beyond 40, then I would suggest every year.
Okay.
Both 2D echo and a stress test. 2D echo will talk about the structure and function of the heart at rest. At my clinic, I do a stress echo, but for a routine screening, from a screening point of view, where many numbers are being done, then a routine stress test also is good enough.
Yeah, and a stress test really is relatively stress-free, right?
Yes, it is. First of all, it is not invasive. You just have to walk on it. It has its fair bit. That is, 20% of the patients can have false positive stress tests. That is, they don't have any heart disease, but ECG shows some abnormality. But then we don't have a non-invasive and cheap. Cheap in the sense because it has to be less expensive. You can't be charging 15,000 for a test just to look for risk, because then application for a wider population will be difficult. So stress test is less expensive, less invasive, and takes up less time. So a stress test, I think, is right now a better bet.
Yeah.
And if the person shows a false positive, nowadays you can do a CT coronary angiogram or a CT calcium score, but CT coronary angiogram to look for if the person actually has heart disease.
Yeah. You spoke earlier, Kedar, about the importance of movement, because one person I thought said it really well. They said the best drug available in the market today is activity or movement. Right? It has got better results than almost any drug that has ever been approved.
Yes.
And yet most of us don't take advantage of it. From your perspective, when you see somebody in their 30s, 40s, what are the lifestyle things in addition to movement that you would tell them to, get right early in life so that you don't have to face the consequences later in life?
I would like to first of all go through their waist hip ratio and all that, and have that optimized. Our body weight has to be optimized to our height. Uh, uh, Based on your, then for that you will have to have a dietitian's consultation, and then physical exercise also, and he has to exercise, not just exercise. What all would could you please repeat the question?
So yeah, I
Sorry,
mean, we are going over so many different topics. I
yeah.
apologize for that. The thing is, what are the lifestyle related factors you would advise patients to focus on so they reduce the chances of having heart disease later?
So first of all, I would talk about increased activity, correct diet. That is not how much we eat, what we eat is more important than how much we eat. So if your diet has more of carbohydrate, more of fat, and less of protein, then it is an unhealthy diet. So what you eat is more important. No ready to eat this like Lay's, Kurkure, packet cola, khadiya. So nothing like that. It has to be brought from the market, cleaned, cut, prepared, and then eaten. So that process, it helps in differentiating healthy from unhealthy foods. Then colas has to be avoided. Then even eating excess of this pickles, achar, excess of papads, be it fried, be it roasted or anything, it increases the salt intake and then raises the blood pressure. So that is what the diet. Then exercise, and with all that, our abdomen should not protrude ahead of our chest. Is the simple principle.
Correct.
That's what if you boil it down to very simple things, this is what it would say.
Yeah. I mentioned this topic to a friend of mine, and he was a very good friend. So I told him, overall fat is, the subcutaneous fat is not as big an issue as the visceral fat, right, around our midriff, around the waist. And so I said, you really need to get that down. And he said something funny to me. He said, the problem is not my weight. The problem is that my height is not optimized for my weight. So I thought that was a funny thing. But I think the markers that you mentioned, keep a track of your visceral fat, right? Increase your muscle.
Yes.
And the way from a nutrition perspective to get there is carbs are fine as long as they're complex rather than the simple sugars. Avoid
Yes.
processed foods. Have more protein. And within fats, within your dietary fat, err more on the side of unsaturated fats versus saturated fats, right?
Yes. But nowadays, the saturated fats, I believe, have been eliminated. But even the regular so-called healthy fats, if they are taken in abundance, they would lead to overweight and excessive. And
Yeah.
being overweight itself has it's a big topic in itself. Increased inflammation, increased uh, 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 atherosclerosis, and all that. It is a big topic in itself.
Yeah.
So simple things is have your belly behind your chest.
Right. Yeah. I think, maybe trans fat has really been taken out of most foods. I think that's definitely been a good development. But yeah, in general, I think those are good things for us to remember on the nutrition side. And of course, sleep, right? Kedar, what's your view on sleep and how much that impacts?
It is important, and sleep rather than duration of sleep is important. 8 hours of uninterrupted healthy sleep, but at what time you're sleeping? So it won't. It should be that he should be sleeping at 10 o'clock and waking up at 5:36, rather than sleeping at 12 and waking up at 8 o'clock.
Yeah.
So duration is also important, and when he achieves that duration. So many people over here in Hinjawadi, they are working for the IT sector. They are working for the United States or Australia. So they are either working in the night and sleeping at 3 in the morning and waking up at 12 in the afternoon. That is something which is totally unphysiological.
Yeah.
So even if the duration of 8 hours is satisfied, it is not really in tune with the nature. So जब सोना चाहिए तभी सोना है और जब उठना चाहिए तभी उठना है.
Yeah. Yeah. No, and this is a very important point that we talk about a lot on this community, which is living by your circadian rhythm. When the sun goes down, have your dinner and go to sleep soon after that. The sun comes up, be awake and start your day. And there was a very interesting paper which showed that out of sleep duration, sleep quality like REM, deep and time you went to bed. Of course, all three are important, but if you could focus on one, focus on the last one, which is when you go to bed. If you can keep that consistent, your entire hormonal release and everything is based on how much you follow the circadian rhythm.
Yeah.
And that also leads to one other topic that's related, which is don't eat your dinner at 10:30 in the night, because that also throws off your circadian rhythm. So sleep, when you eat, all of that matters, not just how much, but when. Are there any supplements? This is a big topic, right? We are in general are very averse to recommending supplements unless they're really critical. And there are a couple, but there are very few. What is your take? Are there any supplements you say, you know what, these are really important, or it's if you can get from your diet, better to get it that way?
I think that it is better to get it from the diet. And if there is a specific deficiency of a certain vitamin, so say vitamin B12 or vitamin D or vitamin C or whatever, if that is documented to be deficient, then taking supplements for the duration that the vitamins are replenished. I think I am of the believer that most of it should be obtained from your diet. And if despite all that you have deficiency of iron or folic acid or B12 or whatever, if that deficiency is documented, then take a supplement.
Yeah.
Otherwise, anyway, you are taking plenty of drugs as it is, because you are controlling your lipids by statins, your blood clotting by aspirin, your blood pressure, your sugars. So on top of it, if you're going to take supplements,
Yeah.
it will add to your risk, to your list.
Yeah, no, absolutely. In fact, that brings us to a topic that is very heavily discussed, and you alluded to it right now. There are two schools of thought. One is if there are specific reasons to do so, take statins. If there aren't, don't. That's one school. The other school is, statins is the devil incarnate. Never take it. It's a way to make money for the pharma industry. And, I'm sure you have a very strong view on this case. I would love to hear that.
Yeah. I think that if your LDL cholesterol, if a patient comes to me, he's in his, say, 30s or early 40s, and his cholesterol lipids are way off the mark. If it is way off the mark, then I start on statins. If it is a little off the mark, then I give a trial of diet and exercise. And if he is able to stick to those two patterns for the rest of his life, then I keep him, and our targets are achieved of LDL, FOB, all that. And then I don't start statins, but I give statins for patients whose lipids are way off the mark, and surely to those who have had a cardiovascular disease in secondary prevention. In primary prevention, also I use statins because taking a tablet helps in reducing the LDL, and at the same time you continue your diet and exercise in the background. It is and how much money somebody else makes is not important. You know, I am a cardiologist, there will be another cardiologist. Another cardiologist may be making more money. I mean, I'm sure. But then there is no use comparing. So, like the pharma company making money, let them make. If statin helps, it helps. And I am of the sure of the opinion that statin, there is no way without statin. In fact, most of my patients who have had a stent have had statins.
Yeah, yeah. In fact, there was somebody on the community who mentioned the other day that there was somebody who told them, don't do it. I'll tell you a lifestyle way to do it. And that's great. If a lifestyle can fix it, that's always going to be best. But if it's not, you can't keep waiting. Or, hey, why magically drop? If it's not dropping after your best attempts, at that point, really consider.
Yeah, let me put it in this way. If 100 is the cutoff limit for LDL, and he's a person XYZ is measured as 120, 130, and he doesn't smoke, he's young, he's capable of doing exercise and everything, then then I would not start statin. I would give a trial for 3 months, 6 months of exercise and diet, and then see. But if the statins are in, say, 180 to 200, then diet and exercise will bring it down from 180 to 200 to 120 to 140. And that is still not achieving the target. So I would start a medicine, however low dose. I mean, it could be 10 milligrams of atorvastatin, and we can go up to 80 milligrams. So we will start statin based on the level of the lipids.
Yeah. No, that makes complete sense. And Kedar, do you also look at triglycerides to HDL ratio?
Actually, it is important, but I have kept things very simple for myself. ApoB and all that ratio, and then homocysteine level, calcium scores. The more the numbers that you have to remember, the more it will repel me away from medicine, because it was numbers that I was running away from when I chose medicine. That's my own perspective.
Yeah.
But it is important. It is very useful. But then there will be a lot of checklists on your panel. So if a person comes to you, his Framingham risk score, his waist to hip ratio, his calcium score, his LDL level, his triglyceride level, homocysteine level, itne sara dekhte, I will see one patient in the evening.
Yeah. No, I think there is no substituting the fact that at the end of the day, you are a doctor making a judgment call, looking at everything. You are simplifying it for us, but I'm sure when you look at it, you are judging them by everything, but you have to, in the end, pick something. So
yeah, so you have to catch on to something. But I know triglyceride to this level is important. But then, like I said, how many things you have to have a checklist? Then it will be a huge, long checklist.
Yeah, understood. I know there are so many more questions that I had for you, Kedar, but we're running out of time, and I want to leave time for questions from the audience. So let me move to those. Let's start with Dhananjay's question. Zone 2 exercise defined as 60 to 70% of target heart rate for about 30 minutes is what most physiologists recommend. 80% of threshold would be zone 3 or zone 4.
Yeah, that is agreed. So you maintain consistently in zone 2 But intermittently, if you touch zone 3 and come down, that is also good.
Yeah. And I want to also provide another sort of a version of this, Dhananjay, and that is the reason there is value in zone 2 and zone 5, right? Zone 2 almost sort of increases your baseline. There are today, I give a specific example. If I were to run 1 mile at a 8-minute pace, which is not a fast pace, it's a reasonably good pace, not a fast pace, I will already move out of zone 2. Okay. And yet I know some people who are so fit that they can run a 6-minute mile in zone 2. And that's because they have trained their mitochondria over time to become more and more efficient, that even with a lot of work, their heart rate doesn't move out beyond zone 2. So zone 2, walking a lot helps you keep increasing your baseline. Zone 5 does a lot of the increasing your VO2 max. It adds that next level. So it's important to do zone 2 and zone 5. Zone 2 is in that 60 to 70%, but you have to also do the pushing of the limits to 80%. Okay?
Very true. Very true. 90% or above too.
Yeah. For someone having neuromuscular disorder and hence cannot grow muscle mass, but is able to do some cardio, what special precautions he or she can take for long-term cardio strength, and what tests are suggested for monitoring?
Oh God, that is beyond my neuromuscular disorders are beyond my beyond my.
So I think that's fair.
It doesn't come in my jurisdiction.
Yeah. I think this question may be answered next week with the neurology expert who will be on the call. But I'll make one comment, and that is the tests suggested for monitoring, muscle mass are a DEXA scan, an in-body scan. They are on the DEXA scan is sort of the gold standard. The in-body is one level lower. And then there are these $25, 2,000 rupee scales you get on Amazon. They are not very accurate, but they're pretty good from a trend perspective. Right? They'll tell you whether you're moving up and down. So don't worry too much about the absolute number. I think your focus should be on, is that number staying flat or getting higher? Because once we are past 30, we have a hard time holding on to muscle mass. It keeps degrading. And so if you could just hold on to whatever muscle mass you have, if you can grow it, even better. But if you can hold on to it, that's great. Use these three things: a DEXA scan every couple of years, in-body scan once a year, or these scales. You can use them every day. They're cheap and they're at home. But we'll answer that question maybe next session. I think, Dhananjay, that other topic we discussed. Ashish, going to your question, can you please clarify what's involved in CT angio and carotid ultrasound as against angiography, angioplasty that was mentioned? So I think there's a little bit of a terminology thing here that if you can just...
Yeah, the CT angiography is done in a CT scan, and it is done in a patient who came walking into the hospital most of the times. In the CT scan, it is reported by a radiologist, and angiography, angioplasty. Angioplasty is the procedure of correcting the blood supply to the heart. That I'll talk at greater length after this. In CT coronary angiography, contrast is injected in the body, and then when it circulates through the heart, the CT scan is done, and in that the blood vessel is taken in multiple sections, and then they are stitched together by software, and that's how we get a picture of the blood supply of the heart. The thinner the sections, the better is the picture. And based on that, they are able to tell whether the atherosclerotic plaque is a soft plaque, or it is a fibrotic plaque, or it is a calcified plaque, and how compromised is the blood supply. If it is, say, up to 50%, then we have to manage it medically. From 50 to 70%, we need something more. That is a functional assessment. That is test thallium or a fractional flow reserve or whatever. and fractional flow reserve is done in the cath lab. And if it is more than 70%, then it does need some kind of intervention, be it angioplasty or a bypass. As for the angiography, it is done through the hand or the leg, and it is done by puncturing the artery of the hand or the leg and visualizing the blood supply by injecting the contrast directly into the artery of interest. And that is called angiography. And angioplasty is putting a wire and then putting a stent into the narrowed segment of the blood supply. It could be narrowed because of cholesterol. It could be narrowed down or completely blocked because of thrombus. So, based on the indication, if it is a heart attack, then it becomes a primary angioplasty. Or if it is a positive stress test and narrowing because of cholesterol, then it becomes an elective angioplasty.
Yeah, that's full primer on everything to do with heart in the last few minutes. But I'm sure, Kedar, this could be a whole topic in itself, right? A deeper dive into what are the interventions for what type of intervention. That's a whole topic, and maybe we'll, if you're up to it, we'll do one more session just on that.
If people are interested and they are happy with what they got in this past 1 hour, I'm sure I will be happy.
Yeah. A couple of other quick questions and then we'll end. Selena asked, along with other risk factors, I have left bundle branch block diagnosed over 10 years ago. Is that an additional risk factor?
No, left bundle branch block per se is not a risk factor, but sometimes left bundle branch block could be a bystander and could be present for no reason. Sometimes it could be a secondary to a manifestation of a heart attack or a dilated cardiomyopathy. That is a heart muscle growing weak, either because of genetic problem or because of some viral infection. And viral infection caused damage to the heart. Then the virus got cleared, but the damage persisted. So if that LBBB could be a manifestation of the damage which could be left behind. So it is if it is isolated LBBB and your heart is per se normal, then it's okay. You just need echocardiogram every 4 years, 5 years. But if it is a manifestation of either decreased blood supply, ischemic cardiomyopathy, that is decreased blood supply to such an extent that the whole heart becomes weak, or it could be a manifestation of myocarditis and the heart muscle becomes weak, then you need a lot of medications and a cardiologist follow-up.
Yeah, perfect. Jitendra, I think to your point, we will make sure that the list of recommended tests that we showed earlier, we will put that on the community so you have that handy to take for you or anybody else who wants to take it to their doctors. You can do so. Sachin, Kedar, Sachin Melankari writes that you yourself are on statin and your LDL is less than 50. You're on mute, Kedar.
The thing is, I also had a stroke, and because of that, there was, and my stroke was due to, I am sorry to say, but it was due to use of tobacco. I had a bit of free time, and in that free time, I used to smoke one per day. But that itself was bad enough to land me in a stroke. And so then all the parameters of cardiovascular system came in. And so LDL actually as low as possible. So be it 30, be it 18 or be it 20, that much is required. So I was put on a 40 milligrams of rosuvastatin and 10 milligrams of ezetimibe, and my LDL remains low. And I'm fond of actually working out. I like it. So I'm more into this muscle training and a little bit less into cardio. And my personal thing is, rather than getting into DEXA and all that, we should follow what old people used to do. Old people is अपने हमारे बचपन में. So You work out till the time that you feel palpitations. For example, you're jogging. So you feel palpitations initially after jogging, say 100 meters. But if you stick to it and you build up pace and you build up distance, then you can do it. You can build up your stamina. So what you used to do initially as only 1 kilometer will gradually grow to 5 kilometers. So train yourself on your own inputs. Your own palpitations will tell you, please slow down.
Yeah.
Why do you want to complicate things by putting in a DEXA, putting in 80%, zone 5, zone 4? You're having a palpitations slow down. You are not having palpitations speed up again and train yourself.
Yeah.
That's a very simplistic way of putting it.
Man, it's good you said that.
The less numbers in your life, the happier you are, is what my thinking is.
Yeah. No, I think there are two very clear set of people. One like that, and then I'm the other extreme. If you give me numbers, I get very excited about life. So to each their own. I think the important point is you have both approaches, and each person should choose an approach that doesn't cause them stress. Right? For some people, numbers are stressful. Then don't go by how you're feeling and all of that, as in your muscle mass, how are you breathing too heavy. But if you are comfortable with numbers, look at them. Whatever suits you, you've now heard both approaches and both are equally valuable. And I'm so glad, Kedar, you shared your story, because most of us think that it can't happen to me.
Yes.
And yet it does. I mean, you are an example, I'm an example. None of us thought it was going to happen to us. It did. And then we had to take statins, and my LDL cholesterol is now 44. I'm on 20 milligram of atorvastatin. Right?
Oh, good.
So
that you've achieved, that's you're lucky.
I mean, I'm lucky that I'm here to have this conversation. I could have easily been a statistic had I not taken that advice seriously. So I know we are well out of time. I know there are a lot of other questions, but I do want to say a very, very big thank you, Kedar, for spending the time, for sharing so openly. It was such a free-flowing conversation, and I am quite confident everybody enjoyed it as much as I did. So I will try and get you to come back, Kedar, because I think there is so many more other interesting things to talk about to continue down this path.
Yes. Thank you very much. Thank you for calling me.
Yeah.
And it was nice, and it was fun. This is the first time in my life.
Good. There's always a first time for everything. So here is ours. All right.
Yes.
Thanks.
Yes.
Kedar, thank you, everybody.